Welcome to The Check-In, the Image podcast lifting the lid on women's health one honest conversation at a time. I'm your host, Ellie Balfe, and in each episode I sit down with some leading medical minds to explore the realities of our health across every decade. From hormones to heart health, this is your space to feel seen, heard and supported as you take control of your health span. Because when women are informed, we are unstoppable. Today on the podcast, I'm joined by Dr Paddy Barrett, a preventive cardiologist and founder of the Heart Health Formula. Paddy describes his work as being in the business of risk evaluation and helping us to manage our cardiac health long before a problem arises. We're talking today about women's heart health and what really matters to living longer and better. Paddy believes that health isn't just about lifespan or health span, but also Soulspan, which is who we are and who we become. And thanks as always to the brands who help us have these wonderful conversations. Image The Check-In is empowered by Boots, sponsored by Samsung, Waterstone Clinic, Irish Life Health and It's for Women. Dr Paddy Barrett, thank you so much for being here.
Good to be here.
We've lots to talk about. Let's jump straight in. You describe yourself as being in the business of risk evaluation. Can you tell us what that means in practical terms?
So I'm a preventive cardiologist. The whole role of a preventive cardiologist is to ascertain or define someone's risk of heart disease early in life and act earlier so they ultimately never get heart disease, or at least get it late in life. The whole key to that is about building a risk model, about understanding the inputs, about what puts someone at risk, and ultimately giving them precise information on that and how to reduce that over time. My approach to doing that is kind of anchored around this idea of health. That is the optimization of three factors. Mm-hmm. It is lifespan, health span, Soulspan. And it is about trying to understand how to optimize those three factors. And so that's how I've set up my practice around defining risk for those parameters and then intervening as needed.
I love the sound of those three pillars of good health. How did you come to them?
So this isn't, I think, an original idea. There's a lot of people who've kind of talked about this before. And it's important to be precise about the actual characteristics of them. Lifespan is how long you live. That's a binary factor. You're either dead or alive, and that time point will exist for all of us. Healthspan is the quality of how you think and move in the world. And Soulspan is how you're going to spend your time with that lifespan and healthspan. So it's a key principle to underpin everything. In my view, the whole function of lifespan and healthspan is to give you the opportunity to enact you to live in a way in the world through your soul span that actually is the most meaningful for you. So lifespan and healthspan are functions of science. They are where we get all our information from clinical trials and studies, etc., whereas soulspan is much more the domain of philosophy and art and literature and music and all those different things that actually, I think, make life worth living. So there's very clear formulas for lifespan and healthspan, whereas soulspan is a much, I think, softer kind of approach.
More esoteric.
But it's why we're here. And so, that's how I tend to approach it.
It's a great framework, actually. It's a great way to approach thinking about your life at all, isn't it?
So the thing is when you're in the business of medicine, the bottom line is you get reminded on a very frequent basis that life is short. Other people get obviously these reminders throughout your life, but you see this over and over and over again. Time is short, and sometimes random things happen and it is cut exceptionally short. So everyone has this pervasive sense of this awareness of their mortality, whether they're thinking about it or not. It's been very well described. Ernest Becker, a cultural anthropologist, talks about this idea of the denial of death. And it's always something that sits, rumbling beneath the surface. So when we then kind of think about this on a practical basis, how are you going to look about extending your lifespan and health span? And you have to look at this on a math basis. And this is where the risk really comes into it. It's not about kind of putting your finger in the air and having a think about what actually might help. You have to look mathematically. And if you look at this, you can see for most adults in the developed world, they're going to die from one of three things: heart disease, cancer, or dementia. We know that if we look at, say, healthy centenarians, so our example population, so we're trying to emulate those groups of individuals, and we ask ourselves, what is it that a healthy centenarian will die from? And what you find is they're not dying from skydiving accidents. They haven't died from kind of their last ascent of Kilimanjaro. You know, it's not kind of some motorcycle race in an Audi TT race.
Sadly.
Yeah, sadly. Or as what they all aspire to is to be shot in the back by a jealous lover, age 95. But what you find is that healthy centenarians die from heart disease, cancer, and dementia. The key difference between them and us is that they get those conditions 20 to 25 years later than everybody else. So it's not that they get different conditions that is the cause of their death. It's they have a phase shift in the timing of onset. So our job then is to understand how can we look at trying to push out later when we get these diseases. Because if you live long enough, you will ultimately get heart disease, you will ultimately get some type of cancer, you will ultimately get some type of neurodegenerative disease. So what you have to do is you have to say, well, what are my risk inputs for each of these three conditions? And we know that the ones for heart disease largely map onto a lot of different cancers and a lot of different dementias. So if you can get the ones for heart disease right, you push out the likelihood of getting the other factors right.
Okay.
We also know that when you talk about Healthspan is the quality of your life in terms of how you will think and move. But the biggest determinant of your health span is whether or not you actually have a major chronic disease. So in terms of, there's often this distinction that people make. They say, listen, I don't want to live a longer life. I just want to have a good quality of life. But the reality is they are inextricably linked.
Yes.
And so if you do the things that will increase your health span, you will by extension increase your lifespan. And we know that by ultimately identifying very clear factors, and if you get them right early in life, you can increase your health span. So that is the number of years you have lived without a major chronic disease, on average by 10 to 14 years.
Wow.
So this isn't about living to 150 years of age. It's about trying to optimize the most that you can get out of the time that you will likely have. And with that time, at that higher quality of life, how are you going to spend that time? And so that's how I tend to frame my whole approach.
Yeah, so it's delaying the inevitability of chronic disease.
Correct. And so people, we describe ourselves as like a preventive cardiologist. In truth, that is incorrect. The correct term would be delayer of heart disease, but it just doesn't sound as good. Because if you live long enough, you almost certainly will get heart disease. The question that most people are trying to ask, however, is, okay, where am I on that trajectory? Are there specific factors that have pulled forward that time frame for me? And am I at high risk now and in the near term? Because if you say to someone, listen, you're going to have a heart attack at 85 years of age, they'll kind of shrug their shoulders and go, listen, that's a problem for, future Homer. Yeah. But the problem that people are trying to address is, do I have a near-term problem? And so we go at this in terms of defining near-term risk and long-term risk, but ultimately always putting it in the framework of how are we going to optimize those three variables.
So let's go back and get a little bit basic for a second. But what exactly is heart disease? What is occurring as we live longer? What's happening in the heart? This
is a really important question that there's a lot of confusion over. Heart disease is an umbrella term. Okay. It can mean lots of different things. It can mean plaque buildup in the coronary arteries. It can mean the damage to a heart valve. It can mean an electrical disturbance. But when people say heart disease, 90+% of the time, we're talking about the deposition of plaque in the major arteries, mostly your heart arteries. That fundamentally happens when a cholesterol particle crosses over the artery wall, becomes retained, sets off an inflammatory process, and then cholesterol plaque is left in its place. And that is what we call plaque. And it's crucial to make the distinction between the risk factors for heart disease, blood pressure, cholesterol, diabetes, the disease that is heart disease, plaque in the coronary arteries, and the event that is the heart attack or the stroke. And our objective is to minimize the risk factors, to delay the onset of the disease, to ultimately never have an event like a heart attack or a stroke, so that you live a long and healthy life and die with coronary artery disease rather than from coronary artery disease.
Yes. So risk factors. What are they? How do we test for them? How do you do your work?
So the risk factors that are the inputs to the model are all the traditional risk factors that we've talked about for years and years and years, with the exception of a handful of smaller risk factors, or being more precise about things. So the assumption is that people think that there's some silver bullet or magic set of factors, but in truth, what it is it's about getting all the core factors right. So fundamentally, if we look at heart disease, you have the cholesterol particle count. So everyone has basically a cholesterol level. It's essential for the functioning of all cells. But the reality is that we know that the higher the number of cholesterol particles that hit off your artery wall over a lifetime increases your risk of one of those particles crossing over and becoming retained and developing as plaque. So cholesterol, in terms of your concentrations, is a key component. There are, however, other risk factors that integrate into that. So the analogy that I use with the cholesterol particles is that you're throwing a tennis ball at a glass window. The more tennis balls you throw, the higher your cholesterol, and the greater the likelihood that one of them will cross over. But if you have, say, high blood pressure, for example, you're just throwing those tennis balls harder. If you have diabetes, you're now throwing golf balls instead of tennis balls. If you're a smoker, you've walked up to that glass window, you've hit it with a hammer, and all of them just sail right across. So it's not that there's one particular risk factor, it's how they all integrate together. And you can be doing really well from a cholesterol point of view, but really badly from a blood pressure point of view. The second, I think, more global aspect of this is around your metabolic health. So we talk about, this is really down to your ability to dispose of glucose. And the abnormal version of this is diabetes. But everyone exists on a continuum from being insulin sensitive, so very efficient at disposing of glucose, or very poor at disposing of glucose. And that is diabetes, type 2 diabetes in its most extreme sense. So the two big ones really are how many particles are hitting off your artery wall, and in the context of what? Metabolic health. And they are the classic risk factors of your cholesterol, your blood pressure, whether you have good blood sugar control, whether you have excess visceral fat, and that is the fat contained in your abdominal cavity. That is a big driver of insulin resistance, whether you're a smoker, your degree of physical activity accumulated over time. And those all integrate together to ultimately provide your risk model. And that is really about trying to understand the inputs. None of those factors, however, tell you whether or not you have heart disease. They're just building a model of risk over time and telling you the factors that you can control. Whether you have heart disease is a different question.
Okay. It's about building a picture of what all of these elements are doing within your system.
Correct. And the biggest risk factor for heart disease that most people miss is time.
Explain.
So, because it's the function of how many risk factors do you have impacting your coronary arteries for as long as possible. So if I give you a cholesterol of, say, 10 today, that sounds exceptionally high.
Yeah.
But if it's just for today, the cumulative exposure is very low. But if I give you a cholesterol of 10 for 50 years, it's very different cumulative exposure. So it's how high is the risk factor and for how long. And where this often comes up, particularly for females, is that they will have spent much of their life with pretty low cholesterol levels. They're fit and healthy, they're doing everything right, and then all of a sudden menopause hits.
Yes, what happens there?
And then everything starts to change. We see increases in blood pressure, we see increases in visceral fat, we see increases in cholesterol levels, and all these different parameters. The thing that is important to identify in that group is the time function. You have to remember that for most of the time that you have been around, those factors have been controlled.
Okay.
It's not to say that we don't need to control them now, but the thing that drives your risk the most is how bad have those risk factors been for how long?
For how long?
And in general, for most healthy females, for most of their life, they have been well under control. So even though they may develop high cholesterol, the time period where they have high cholesterol is actually quite minimal at that time period when they go through menopause. So that always needs to be put in context.
Yeah, okay. So if you can consider menopause as a moment in time where things become out of balance or in a different balance because of the hormonal drop, is it the drop in estrogen that's causing it? Or
that's the primary change that we see. So when we talk about the key difference between males and females, there's often an assumption that females are at lower risk of heart disease than males. Males and females will die with equal frequency in terms of heart disease. The key distinction for most females is that they will get it about 10 years later than males. So they get a 10-year almost health span advantage.
But they will die at the same rate.
But they will die, yeah. At the end of the day, if you're just counting up the bodies to sound as kind of as grim as that is, there will be an equal pile from the heart disease in the males and females.
Right.
But that pile will start building sooner in the males.
Okay.
The key difference, however, is that 10-year advantage is eliminated if the female has A, a genetic cholesterol disorder, or B, goes through very early menopause.
Okay.
Because so in males, their cholesterol levels and cardiovascular risk factors start to worsen in their, say, 20s, 30s, 40s. Approximately 10 years later, for females, except if they go through an earlier menopause, when it gets pulled forward and then maps onto the male pattern of cardiovascular risk change.
And what's happening post-menopausally then for women?
So post-menopausally, there's obviously this sudden catastrophic drop in estrogen. Some females really notice this in terms of a whole variety of vasomotor symptoms, changes to their sleep, mood changes, sleep, night sweats, the whole lot. But in terms of cardiovascular risk, we see increases, as I said, in visceral fat. That is the fat that drives basically excess risk in terms of insulin resistance. You see changes in terms of how blood pressure is managed, in terms of nitric oxide production. So the vessels constrict more, blood pressure goes up. We see cholesterol levels rise precipitously. So you get this whole constellation of risk factors that historically were not present, but have now suddenly appeared.
And will they stay high? Will they stay elevated for the rest of a woman's life? They continually have to be monitored, or will they rebalance?
So this is where we start to get into the discussion around, well, if these changes have happened during this particular period, which is largely driven by a drop in estrogen, is the replacement of that estrogen going to just simply correct the change that has happened? And the answer is the degree of risk reduction that you get in terms of those risk factors with the introduction of HRT is not anywhere near in terms of the magnitude that you get in terms of the worsening. So cholesterol goes up precipitously, but if you put someone on HRT, the reduction in their cholesterol levels is actually marginal. Blood pressure goes up often, and when you put someone on HRT, the reduction in blood pressure is often only marginal.
Okay.
And same with weight, for example. So it's very frustrating that you get a key change physiologically that with a correction of it in terms of using a supplemental estrogen or progesterone, that you don't get kind of a commensurate reduction in those risk factors. You do a lot of the time get a change in vasomotor symptoms or kind of sleep disturbance, etc., or mood or anxiety. But in terms of the cardiovascular risk factors, we often don't get the same proportional reduction as we get in terms of risk.
Really?
So we have to use often kind of other strategies to tackle that.
Okay. So going back a bit to your initial risk assessment or evaluation of if a woman comes to you, what tests do you run? Like, how do you really evaluate a woman's risk?
What I would say is I don't make a distinction between kind of a male and a female, because the risk factors are largely kind of the same. So this is a key thing, is that you are fundamentally going to be evaluating their lifestyle factors. So the way I think about this is in a pyramid of risk. It's about understanding the 4 pillars that we have available to us in terms of exercise, nutrition, sleep, and stress. So from an exercise point of view, are they hitting their targets from an aerobic exercise point of view, resistance training point of view? So, and have they translated into appropriate levels of physical fitness, either by way of VO2 max for kind of taking it kind of to the extreme, or muscle mass? Nutrition, in my view, is largely around how you maintain your visceral fat levels. So what you're really looking for there is, a crude assessment is going to be BMI, but really what you're looking for is excess weight and any metabolic changes that go with it. So in my view, so blood pressure, higher cholesterol levels, insulin resistance, high triglycerides, low HDL. These are all markers that you can measure as blood tests. Sleep, are they getting adequate sleep? Do they need to think about how they would extend the amount of sleep that they're getting? Do they have a sleep disorder that's actually impacting their sleep? And then fundamentally, stress. Are there a set of other factors in their life that are impacting their ability to hit the other 3 metrics in terms of exercise, nutrition, and sleep? Because if stress goes, all the other 3 become much harder to hit. So you're less likely to be getting a proper night's sleep. You're less likely to be hitting your nutrition targets to maintain your weight levels. You're less likely to be hitting your exercise targets across those things. So that often becomes the biggest determinant, but often the hardest to fix.
Yes, sadly. Paddy, can you explain to us once and for all what LDL, HDL, triglycerides, like all of these elements within our blood panel actually mean?
So when you think about cholesterol, we're always going back to that particle, that tennis ball that's hitting off the artery wall. The particle has 2 ingredients, LDL cholesterol and triglycerides. So it is the tennis ball that has those ingredients. That is broadly what is being measured on your cholesterol panel. When you look at someone's panel, the tennis ball will either be very full of LDL cholesterol and not have that much triglyceride. So triglyceride's a fatty deposit. LDL is a cholesterol deposit, and the tennis ball moves them around your body.
Mm-hmm.
LDL is largely determined by your genetics, and therefore often to lower it, you need to use a medication. Triglycerides is largely determined by your lifestyle for most people. Okay. So therefore, to lower the number of tennis balls, you're leveraging more on lifestyle factors, weight reduction, increases in exercise. So when you look at your cholesterol panel, the things that you need to look at are, do I have an issue of high LDL cholesterol? Often, very frequently, an issue of genetics. Or is it an issue related to triglycerides? An issue of lifestyle. So that will give you an indication of what tool you'll need to solve the problem. Mm-hmm. But it could also be both. And if you look at your cholesterol panel, the most important factor to look at is what's called your non-HDL cholesterol. It is your total cholesterol discounted by your HDL cholesterol. And so that's non-HDL, total minus HDL. And that will often be listed in your blood panel results, but sometimes not. That is the best approximation of the number of particles that are hitting off the artery wall. And that is the best estimate of your risk. Those number of particles could be because of lots of LDL cholesterol, lots of triglycerides, or both. But each individual component gives you an idea of what tool you're going to use to solve it.
So that's the number we need to know?
Correct.
Okay, and that's what we need to ask for?
Correct.
Okay, what's ideal? Is there a number, generally speaking, that we need to be under or around?
Optimal is a non-HDL of 2.2. Reasonable or pretty good is a non-HDL less than 3.
Okay. And what about LDL, which we hear is the bad one?
It's bad only because it increases the number of particles, which is best estimated by your non-HDL.
Okay. So what happens next? So you've assessed, so somebody comes to you, you've done this risk assessment, if you will. What next?
So generally what we do is a person will have come to us with a set of, say, blood tests or metrics done by their primary care doctor. We then think about kind of additional tests that we may need to do on top of that to integrate to build a risk model. The first one that we often do that is rarely done by other clinicians is assess whether they have a genetic cholesterol disorder for a condition called lipoprotein A or Lp(a). It impacts about 10 to 20% of the population and is one of the biggest kind of drivers of early heart disease.
Okay.
So that's something that loads of people have it. They just don't know that they have it.
And this is not done on normal bloods?
This is not available on kind of normal bloods. It's often very hard to get done in primary care. And so when I hear the story of dad had a heart attack at 50, his dad had a heart attack at 50, his brother had a heart attack at 50, this is the first thing that I'm thinking of.
Sure.
All of the things we've talked about so far are risk factors in terms of the inputs to a model. The question then we need to ask is, at this time point, have you started to generate or accumulate plaque in your coronary arteries? Because we have risk factors, disease, event. And certainly in the short term, you can't die from a condition that you don't have.
Yeah. So
you may have loads of risk factors, but the question is do you have any evidence of plaque? Because it's the plaque rupture that's going to cause the problem. Because it's technically incorrect, but largely people don't die from heart disease. They die from heart attacks. And so the more plaque you have, the higher the risk of a heart attack. And this is the question that most people are trying to understand. They know that they have a set of risk factors. Some of them they know about, some of them we will uncover. The question that they're really trying to understand is what is the risk of a heart attack or dying suddenly in the near future?
Yes.
And that is when we start to move on to imaging tests like, say, a cardiac CT, which basically looks at the heart arteries and says, is there any evidence of plaque? How much? What does that mean for your risk of a heart attack over the next 10 years? And how do we go about kind of reducing that risk? Because if you take someone in, say, midlife who has some risk factors, but they don't have any evidence of plaque, we've got a lot more latitude about how we manage those risk factors in terms of we don't have to jump straight into any medications or things like that.
It's potential. It's not a problem yet.
Yes. And so we know that you've got the risk factor, but the question is you don't have any evidence of the disease in the advanced state. So your risk of an event is actually low in the near term. The question then is how can we then modify your risk factors that are kind of concern, be it blood pressure, cholesterol control, pre-diabetes, insulin resistance, maybe it's poor sleep, for example. And then that then decreases your risk of an event. It's different, however, if someone is actually now plaque accumulation, because that changes things. Because now they have evidence of the disease that increases the risk of an event like a heart attack. So we have to be much more aggressive in that particular individual. So if you have someone who has moderately elevated cholesterol, for example, we're much more likely to talk about maybe some of the dietary strategies that will work for getting them down to an optimal level and see if that actually works for them. But if someone's got plaque, it's a different story.
Okay.
Our thresholds are much more strict, and we typically start to think about using medications much quicker for that individual.
Would they be statins?
So statin therapy is a cholesterol-lowering medication, but we've lots of different cholesterol-lowering medications. Statins just tend to be very well studied, generally very safe, have been around for a very long time, are cheap and effective.
Okay.
But they're just one of the tools that we have available to us.
Right, okay. Paddy, what is actually happening in a heart attack? So you've got this cholesterol buildup. What happens next?
So you have a risk factor, a cholesterol particle, that has moved across your artery wall and built up as plaque. That plaque is generally, in an untreated individual, a soft gel-like substance. What happens with a heart attack is that gel-like substance, if you think of it like a blister in the artery, ruptures. Yeah. And the cholesterol in the wall has now made contact with the blood in your blood vessel. That sets off a clotting cascade. And ultimately a clot, just like the way you get a scab on a cut on your hand, for example, now forms in the artery. But it is the scab or clot that ultimately stops the blood flow down the artery. And so now you no longer have blood flowing down the artery. The muscle of the heart is now deprived of oxygen and it starts to die. That is a heart attack.
That's a heart attack. And then similarly with the stroke?
Basically the same process, different territory.
Yes.
So you have a plaque rupture, generally, in a neck artery. You have a reduction in blood flow, or you can have the actual clot itself moves into the brain, finds the smallest blood vessel, it will block, and then ultimately blocks blood flow that way. That accounts for the majority of strokes, but certain strokes can be caused by bleeding in the brain too.
Yes.
So it's not exactly the same, but if you think of a stroke like a brain heart attack, it's roughly sufficient to think of it that way.
And cholesterol also, that impacts dementia as well?
Correct. And this can be a very controversial subject. The bottom line is that if you look at cardiovascular risk factors, cholesterol being one of them, we have very good evidence to support that higher cholesterol levels for longer increase the risk of dementia. We know that in all the cholesterol lowering studies, when you put them all together, that you actually get a reduction in the risk of dementia when we look in observational studies. So these are not randomized studies. We don't actually have that data, but our observational data would suggest that. The problem is that if you look at some groups online, they will say that, say, statin therapy causes dementia. The totality of that evidence is not there. And the overwhelming evidence would say that statin therapy, or any cholesterol-lowering medication for that matter, is linked to less dementia, not more. The distinction that needs to be made, however, is that there are some individuals, generally a very small number, who go on something like statin therapy and will get some, say, brain fog or maybe a little bit of forgetfulness. It's not very, very common, but if you stop the medication, those symptoms go away.
Okay.
Now, the key thing there is those symptoms appearing as a consequence of being on that medication is not the diagnosis of dementia.
Right.
So that is simply an adverse event of being a little bit confused, as opposed to the diagnosis of dementia.
Okay, interesting. Going back to what you said there about the time frame, or for how long, I think that's very interesting. So many people are going through their lives and they don't know the risk factors that are going on inside them. When should people start testing? Like
today.
Today. Okay.
No, and that's, so this is
in your
really
20s,
important.
if we were
Today.
to go by decade?
Today.
Really?
And the answer is always today.
Okay.
So the reason being is that if you go back and look at autopsy studies of people who've died from non-cardiac causes, even in their 20s, you will routinely find the earliest stages of plaque accumulation. And
in 20s?
In their 20s. So this was originally done in returning soldiers from the Korean War. Now, so these soldiers would have died in their 20s, early 30s from combat-related injuries, so not heart attacks. When autopsies were done on those individuals, the absolute majority of them, 77% plus, had the earliest stages of plaque accumulation. Now, you can say at that time, other risk factors were much more prevalent, things like smoking, for example.
Right.
Fast forward to basically similar studies done on heart transplant donors. So this is a younger individual who sadly died in something like a road traffic accident, and we do an evaluation of their heart arteries prior to them becoming a donor. And you find over and over and over again the earliest stages of plaque accumulation. The almost overwhelming certainty is that if you were an adult listening to this, and we were to use a microscope to look at your coronary arteries, there would be the earliest stages of plaque accumulation.
Okay.
And remember, the biggest risk factor for heart disease is time. We can't change the direction of time, but we can change the risk factors and their magnitude as they're exposed to your arteries over time.
Going forward.
Exactly. But the analogy here is the compound interest benefit of a pension. The earlier you start, the less of an extreme magnitude change that you need to make to ultimately accrue the benefit. So it's about time. So if you start earlier, you get time on your side. And that is the biggest risk factor for heart disease. But if you can start earlier, you get it on your side.
Right. And is there any difference between men and women in terms of time in it building up earlier or not?
There is, yeah. So in general, females have heart disease onset in an advanced state about 10 years later than males.
Yeah.
But that's because of the risk factor profile. But with the exceptions, as we said before, unless you have a genetic cholesterol disorder or very early onset of menopause.
Okay. So again, we go back to somebody who comes to you, you're running your tests, you've done some imaging potentially, you've looked at their entire lifestyle, their nutrition, their exercise, their genetic path, what is going on in their family. What are you doing for them then? You're putting them on an action plan?
So the first thing we're going to do is say, where are the risk factors abnormal? Is it just cholesterol, or is it blood pressure? Is it both? Is it glycemic control? So we've identified kind of where the risk may be coming from. Is it a genetic cholesterol disorder? Is it an unknown factor? Has that translated into plaque? So that then kind of tells us, listen, you've got maybe say like an 8% risk of a heart attack over the next 10 years. So
and that is an actual metric that can be worked out. You
100%.
Give someone a percentage.
Yeah, 100%.
Wow.
And we also know that if you have no evidence of advanced plaque in your coronary arteries, so a calcium score of 0 and a normal CT, cardiac CT, your risk of a heart attack over the next 10 years is generally less than 2%. So it's super low. Okay. The question then becomes, well, where do we feel the risk is coming from? Is it, for example, blood pressure that the risk is coming from? If it's blood pressure, our ability to modify that metric using lifestyle changes is actually quite substantial. Yeah. So we know that weight reduction, proper sleep, identification if they have a sleep disorder of obstructive sleep apnea, in some individuals, reduction in salt, switching out to say a potassium-based salt rather than a sodium-based salt, understanding their alcohol intake, and dialing that down. And then you say, well, listen, I think it may be coming from here. We'll just say it's sleep, or we'll say it's salt, or we'll say it's, excess weight. We dial down, we put in a plan to tackle that risk factor, and then we see, does it change the variable
over a period of time?
Over a period of time. Yeah. So it's you're always measuring and mapping and rebuilding out your risk model. And when it comes to blood pressure, this is a really crucial point to identify. Approximately 50% of adults will have high blood pressure.
50?
Of adults, yes. Okay, when you hold it to the strictest terms. Okay. Half of those will be undiagnosed. Okay. Of the half who are diagnosed, half will be untreated. Of the half who are treated, half will be suboptimally treated. Wow. So we do a really bad job in general of identifying and managing appropriately high blood pressure. We know that high blood pressure is the single leading cause of early death worldwide. It's the number one risk factor for stroke. And we know that it is extremely easy to identify. We don't do it. It is extremely easy to manage, and we don't do it.
Why don't we do it?
Number one, it's not managed. Most people are just totally blind to the metric of whether they have high blood pressure.
So it's a lack of awareness. Correct. On behalf of the individual?
On behalf of everyone, so including kind of medical establishments as well. Okay. For example, checking your blood pressure in your doctor's office to identify whether you have high blood pressure is as close to useless as makes no difference in my view. Okay. Okay. In my view, it's pure theatre to check someone's blood pressure in a clinical setting if you're trying to identify whether they have high blood pressure.
Yeah, for one, you're testing it in one moment in time.
One single moment in time that's entirely contrived. You're dealing with bad parking, bad traffic, bad coffee, kind of take your pick. If you think you're going to get an accurate reflection of someone's blood pressure in that particular moment and a single one-off reading, it's just not true. So the thing that I say to all of my patients is that I am of the KGB mentality. Trust but verify. And the way that we do that is that person will get their own blood pressure monitor that goes over their upper arm and not over their wrist. They will, over a 10-day period, measure their blood pressure first thing in the morning and do 3 readings. They're going to get rid of the first reading, and then they're going to average the second and the third, and then they're going to do that for 10 days in a row.
Okay.
The average of those over that 10-day period, that is your blood pressure.
This episode of Image the Check-In is empowered by Boots. Boots pharmacists are with you for life. They are often the very first stop when it comes to advice, care and guidance. For all facets of women's health at every age and every stage, Boots is here to help you feel informed and supported every step of the way. We are proud to partner with them to bring you the knowledge you need to future-proof your health. And is that your blood pressure for that age of your life type of thing, or how often do you need to do that?
So what I would recommend to every single adult is that they do it 3 to 4 times a year.
Oh.
So a 10-day snapshot 3 to 4 times a year. So am I at target? Yes or no? Do I need to do something? Yes or no? You do it prior to a consultation with your doctor, whereby your blood pressure is an important variable. You do it after you have any changes made, either lifestyle or medication, to see did they get to the desired effect. So what matters is your blood pressure at target? It doesn't matter the kind of approach that you're taking, whether it's lifestyle or medications or even the type of medication. The bottom line is it at target? And so if you go into your doctor and you're told that you have high blood pressure and they go, here's a blood pressure medication, it's not a fire and forget approach. It's, did that treatment get you to target? That's what matters. Outcomes matter more. So your blood pressure is high, we put you on a treatment, you tolerate it, you recheck. Are you at target? If not, modify. And you keep doing that process until such time as you get to target, and then you can change out the frequency of measurements. And the same applies to all the different metrics that we measure.
So I'm thinking the same around cholesterol. So if people go to their GP, they're getting one blood test, that's cholesterol in that moment. Is that fair to say?
So it is fair to say, but the likelihood of that being correct as a fasting sample is very, very true. So you can say, well, that is what it exists for right now. Do I need to make any changes? And ultimately, how far am I away from my optimal level? So when we're looking at this, my objective here is that you're trying to maximally reduce your risk of heart disease. But that's not true for everybody. People sometimes don't want to participate in that process, and I don't really have much to offer. But the reality is you're always saying is, how far is my risk factor variable away from optimal? And we know that if you take, say, cholesterol, for example, you go in, you've high cholesterol, you've decided to go on a medication to lower that cholesterol. The question fundamentally is have you gotten to target? It's not, am I on a cholesterol lowering medication or not? And so I see this over and over and over again. Someone said, I had high cholesterol, I went on a cholesterol lowering medication. And you say, well, where's your cholesterol now? And it's like, I don't know.
Yeah.
So the reality is where are you now? What is your target? Have you gotten there? And it's rinse, wash and repeat.
I think that's the experience a lot of people have, is you go and you do a blood test, maybe once a year, maybe every 18 months, not frequently enough, and then get this high reading, particularly of cholesterol, and then just go off and try to change their lifestyle, but have no way of tracking it. They don't go back to the doctor, and that's where the danger lies, really. We need to know what we're looking at and how to change it.
True, but you also need to say, is the juice worth the squeeze? And so people have, I have no interest in lowering a number. I have an interest in lowering risk. Yes. So this is when it goes back to you're building a risk model. So when you take an individual, say, and so this is a very classic scenario. You have a perimenopausal female who has had historically normal cholesterol. They've now checked their cholesterol levels. It's super high. They're concerned. They end up in front of me.
Yeah.
We go through things. Your cholesterol is high. We do a cardiac CT. They have no evidence of plaque accumulation. Their near-term risk is low. Now we say, well, okay, listen, we've got a bit of flexibility here. There's no very high risk in the near term. We don't have to get concerned in the kind of the immediate term. How do we get to target? And so the general approach is listen, things aren't too high risk. Don't need to be too worried. Over the near term, that's true. Just you need to ease off in the diet, do a bit more exercise. Number one, exercise makes almost no difference whatsoever to your cholesterol levels. But then the question is, practically not, depending on, it will lower your triglycerides, but not your LDL cholesterol levels often, which is the one that we're looking at. The second thing then is, how do we get you to target? And it's like, you need to ease off in the butter. You need to kind of eat a bit more kind of veg. And so what the more precise recommendation is you're reducing saturated fat and you're increasing fiber. And so this is the thing that most people will be told. And what they're not told, however, is that for the majority of individuals who do that, they will either get approximately a 15% reduction in their LDL cholesterol, which is directionally helpful, but rarely sufficient to get them to target, or they may have no change at all. But some individuals will get a big change. But again, this is where we trust but verify. Here's your level. Here's the recommendation in terms of kind of the dietary changes that you're going to make. Now we're going to recheck, did you get to target? If not, do we need to add a medication to actually push you lower to get to target? The question of the medication is not a question of lowering the number. It's a question of, is the risk reduction that comes with lowering that number worth it? And so if you take, say, someone with a calcium score of 0, their risk of a heart attack over the next 5 to 10 years is generally about 2% or less. Going on a cholesterol lowering medication will reduce that risk about 25%, which sounds great, but it's 25% of what? It's 25%
of very
2%.
little.
So you go from a 2% risk to a 1.5% risk. And then people will hear that and they'll go, well, hold on a second. I'm not going on a medication. That doesn't sound like a good bet. And I go, that's over the next 10 years. But I'm not interested in the next 10 years. I'm interested in the next 50. And so if you actually look at the time horizon of their risk, it will increase over time because the biggest risk factor for heart disease is time. And so as they get to 60, 70, 80, that risk is climbing. And that same 25% risk reduction becomes a much bigger absolute risk because 25% of a big number is a big number. And so this is where we have to be honest with our patients. And we have to say, listen, in your particular scenario, going on this cholesterol lowering medication is not about preventing a heart attack in the next 5 to 10 years because the probability of you having a heart attack in the next 5 to 10 years is really low. And that's very reassuring for a lot of people.
Yes, of course.
However, if you want to invest in reducing a risk factor over time, this is a way to do it. But it is about investing in risk reduction for 30 years' time. And some people will look at that risk bet and they will go, that doesn't seem like a good bet to me.
Okay.
And you will go, okay, because I'm not here to tell people what to do. I'm here to help people hit their goals.
Yes.
And so if you're highly averse to the idea of going on a medication and you understand that that's the risk calculus for you, you know, we just have to accept that. But if you want to be very aggressive about it and you want to really invest in lifetime cardiovascular risk reduction, you can take this strategy. And so again, when it comes to getting your cholesterol to target, I don't really care how we do it, just that we get to target.
Yes. So it's about somebody's time investment into their longevity at a particular point in time.
Correct. So if we take individuals, say in their 20s, and we follow them for 35 years. We look at the people who, on average, their risk score is high. So that's across their nutrition, exercise, cholesterol, blood pressure, smoking, physical activity. And so their score is high as in they do really well. They're very healthy across all the domains. And we compare them to the people who are persistently low from their 20s out for another 35 years. The people who have low scores, so poor cardiovascular health, compared to the high scores, are 10 times more likely to develop heart disease.
Okay.
Because it is a function of time and the number of risk factors that they have. We can't control time, but we can control our risk factors.
Yes, okay. So in terms of time and checking in, once somebody is with you and you have them on an action plan, how frequently then, if somebody is saying, okay, I'm going to invest in this, I'm taking the bet, how frequently do they need to test and check and get scanned, and like what does that look like for the years ahead if you've taken the long bet?
So from a risk factor point of view, things like cholesterol changes, you're talking about in 3 months' time. Blood pressures changes can happen kind of in, say, 3 months' time. They're kind of like, you're talking about like short months.
Okay.
But a lot of the time that can be done either yourself or in combination and collaboration with your primary care doctor.
Yes.
And so then they're coming to me, say, kind of on a yearly basis or whatever, maybe sooner if we're trying to kind of get someone there quicker because they're in a much higher risk category. And then once we've gotten them to target across their domains, we extend out the degree of testing. When it comes to imaging in terms of cardiac CT, there's no definitive answer to this, but often we will kind of repeat it maybe at about a 5-year interval. Okay. So that's not something like we do on a yearly basis or something like that. Yeah. But it gives us a rough approximation, again, another data point in terms of has the plaque accumulation increased to a substantial degree that would make us more concerned to change an action course, for example.
Yeah, okay. Okay, so people can lean back into their GP, to their primary care, and keep going along the plan.
It has to be a collaborative process between all parties involved. Yeah. The patient has to be actively engaged, the consultant will be actively engaged, and the primary care doctor actively engaged, and it's a collaboration between all three.
Yeah. Talk to me a bit about weight and obesity, and I know it's on the rise in Ireland in particular, but for women as well. There's so much talk around GLP-1s, all of these medications. And it's interesting what you say sometimes about removing the moral narrative or this idea of shame, or it just being around weight loss. There's a lot of that circling around the discussion, I think. You prescribe them. Tell me the benefits that you see.
So, as I said at the start, the two big factors are going to be the number of cholesterol particles hitting off your artery wall and your metabolic health. Okay. Now, I'm not really interested in weight. I'm not here to manage aesthetics or how people look. I'm here to manage risk. GLP-1 medications and the whole class of medications are an incredibly potent and powerful tool at reducing excess weight that is in the wrong place that is causing a metabolic consequence. And so with those tools, I can significantly de-risk someone over time. And so the problem is that when it comes to weight, as you pointed out, is a lot of people have a very strong moral opinion about it. They believe that it is down to a personal failing on that particular individual's behalf. Because we know that if we were to take that individual and we were to lock them in a box and not feed them enough and get them to exercise on a bike, they would lose weight. So then the solution has to be kind of, you need to eat less and move more. The problem is the degree of calories you consume is largely driven by your appetite, which is set in about 70 to 80% of the time by your genetics. So your genetics drive where the thermostat of your appetite is, and that changes over time. And so this is a losing battle for most people over longer periods. The classic story is someone says, I need to make some changes. They make some changes and they do it for, say, 6 months. Everyone's a winner at 6 months. But the reality is when it comes to 1 year, you can't overcome and overpower the thermostat that has been set. And we know that to lose weight, you have to be in a caloric deficit. But everybody knows that being in a caloric deficit is miserable.
Hard to maintain.
And what happens is these medications adjust the thermostat of your appetite. They make the caloric deficit much more acceptable for you as an individual, and therefore the likelihood of you achieving a weight reduction and maintaining that weight reduction. And that weight reduction then comes with substantial metabolic benefits and reductions in your risk. And as I said, I'm in the business of reducing risk, and this is an incredibly powerful tool to do that. The interesting part of these particular studies is, number one, if you look at dietary changes, everyone's obsessed with the particular diet to use. Do you want low carb, low fat, high protein, alkaline diet, blood type diet? Take your pick, facing the planet of Jupiter diet. The bottom line is everyone's a winner at 6 months as long as you can achieve a caloric deficit. If you look at success at 2 years, 50% of people will have regained all that weight. At 5 years, 80% of people will have regained all that weight. And even the 20% of people that have lost weight and maintained it over 5 years, the degree of weight loss that they achieve is rarely sufficient to adequately de-risk them from the degree of excess weight that they actually have. So the recommendation of eat less, move more, if it were tested in a drug trial, would never be approved as a drug. So therefore, we should never really be broadly kind of applying this. It is technically true that if you did it, it would work, but it is largely not under your control. And so this is where these medications come into place. You have an individual who has tried multiple times and tried and failed and tried and failed. They have excess risk, and we can take that risk off the table using one of these medications. We know that Using these medications in high-risk individuals is associated with a 20% reduction in risk of heart attacks and major heart events. We know that fatty liver disease, which is a marker of insulin resistance, gets substantially better. Osteoarthritis gets better. Obstructive sleep apnea gets better. We have observational data to suggest that cancer risk is reduced and also dementia risk is reduced.
It's incredible.
So if I have a tool that can achieve that degree of risk reduction, I'm not going to be bothered by people's moral opinions of these medications. I will use the tool in the individual who wants to hit that target.
I imagine they will just become similar to any other medication, to a cholesterol lowering medication or anything else we're taking.
So when was the last time you think you gave someone a hard time from a moral perspective that they couldn't get their blood pressure or their cholesterol under control,
right,
and
never.
that they resorted to a cholesterol lowering medication or a blood pressure lowering medication? These will fade into the background of just the simple set of tools that we use to manage a risk marker. I have no interest in getting into the moral discussions of weight. I'm interested in managing risk, and these are really useful to do so.
Yes, longevity, not aesthetics, right? Makes sense. Nutrition-wise, it's said the longer the shelf life, the shorter your life. Agree?
No.
Oh, ultra-processed foods.
I think that the risk associated with ultra-processed food are wildly overblown.
Tell me.
The reason being is that there is a very clear relationship between ultra-processed food or processed food intake and worse outcomes, shorter life, etc. No doubt whatsoever. The absolute majority of that risk is driven by excess caloric intake as a consequence of that food,
right,
rather than something magical in them in terms of certain horrible ingredients that are in ultra-processed foods. Ultra-processed foods are a problem because they are typically extremely calorie dense and nutrient poor, typically from a protein perspective. So they're just a very, very quick way, an efficient way of getting you to a calorie excess. We know that when people are given the opportunity to eat either unprocessed foods or processed foods, on average, they will consume several hundred calories more per day, just on the basis of consuming the processed foods. And over a 2-week period, will put on about close to a kilogram in excess weight.
Wow.
So the issue here is not necessarily the processed foods. It's the calorie density of those foods, our ubiquitous kind of access to them, and their palatability. So it is really important for me to say that when somebody eats a processed food, they've bought a yogurt in the supermarket. God forbid they even fed it to their children. Oh my God. The bottom line is it's the caloric content of that food primarily that's driving the risk. So if you're consuming a processed food in the context of a diet that is controlling your calories and that has adequate amounts of protein, the degree of excess risk is likely to be incredibly small. We do know that within those studies of processed foods that there is a signal that stands out as a standalone feature of the processed food for highly processed red meats and for sugar-sweetened beverages. But again, I would imagine the sugar-sweetened beverage is it's your mainlining calories. It's the quickest way to actually to do that. People want to demonize these foods as there's something terrible within them. The problem is they're just a vehicle for a very quick way to gain excess calories and then deposit that as visceral fat.
Okay, understood. Talk to me about inflammation. We hear a lot about inflammation at the moment. What's that doing to our hearts?
So inflammation is a core component of pretty much most chronic diseases. From cardiovascular disease, it is responsible for damaging the cholesterol particles, for increasing the likelihood that they cross the wall, increasing the likelihood that they become retained in the wall, increasing the likelihood that a plaque in your artery ruptures and causes an event. So we know that without a doubt, inflammation is critical to each and every step and phase of heart disease as we talk about it. The problem is that we have very poor ways of measuring inflammation.
Yes.
So there are tests, high sensitivity CRP, for example, that give us kind of a rough idea of inflammation. But we know that most of the inflammation will come from the core metrics that we will look at, whether someone has excess weight and excess visceral fat, whether someone is a smoker, someone has hypertension, for example. And so it has become very fashionable to talk about inflammation.
Yeah.
But in my business, you have to look at this on a math basis. I need something to put into the model. And so when we talk about broadly about inflammation, it is true, but I have to say, listen, how am I defining that inflammation? Now, you can define inflammation on the basis of the kind of the downstream consequences of insulin resistance, for example. But when we talk about inflammation, it's extremely hard to measure accurately in normal clinical settings. We have slightly more advanced tools in research settings. But then we also have to look at, okay, here's the metric. Is there an objective measure of inflammation? What am I going to do to reduce that inflammation? Has it succeeded?
Okay.
So
it's all about the measurement.
Yeah. And so, if it's not measured, it's not managed. And so while we have the metric, CRP, as a marker, it's very general. You could have that from a kind of a chest infection, an infection in your toe, an infection in your head, so we don't know. And so when it comes to inflammation, it is a crucial component of all those things. But when it comes to objectively measuring and managing, it typically tracks with all the other things. So did you get blood pressure right? Have you stopped smoking? Have you achieved optimal kind of weight? The inflammation reduction will come with it.
Okay. And then thinking of measuring and tracking ourselves, what do you think about wearables and apps and that whole space for women and everybody? How can we accurately collect some data that we understand and then know what to do with?
The last part of your question is the most important.
Knowing what to do with
knowing what you should do with that information. There is any amount of wearable technologies available to people that can measure things now that would have been unheard of 10, 20 years ago.
Yeah.
The idea that we can wear a watch that can do an ECG trace that we can record and then send to a doctor full of you after it already being reviewed by an artificial intelligence algorithm to say whether it's atrial fibrillation or not is astounding.
Do people come to you with this data?
All the time.
Okay.
All the time. But the question is the technology and tool that you're wearing, is it useful for you in terms of giving you actionable information that's going to change how you behave?
Yes, exactly.
And that is the most important tool. So you could have a whole suite of different metrics on a dashboard, but unless they are relevant to you in terms of telling you what to do next, it's not helpful. For example, one of my friends who has been overweight for a very long time said, I don't need a weighing scales to tell me that I'm overweight. And he's like, so it's like this tool is useful, is not really useful to me. And so people really run into problems with things like wearable technologies telling them about their HRV or heart rate variability. This drives people absolutely bananas because my HRV is way too low and it's lower than my friend. And it's like, well, what's your reference baseline HRV? How does it change with various different inputs? Now, you can use HRV, but it's a very, very technical thing, needs to be measured very, very correctly. I think most people would do well when it comes to wearable technologies about having a very rudimentary assessment of how long they are in bed asleep at nighttime.
Okay. I
do not believe that there's any commercially available technologies that can measure accurately deep sleep and light sleep. So I think how much roughly sleep are you getting?
Yeah.
The number of steps that you get is a very good crude assessment of the amount of activity that you're doing. We know that if you achieve 10,000 steps per day or 8,000 steps a day as opposed to 4,000 steps per day, you reduce your risk of dying from any condition over a 10-year period by about 50%. If you can bump that figure up to, say, 12,000 steps a day, that risk reduction goes to 63%. So that's a really good kind of measure to say, am I hitting my targets? And do I need to change something to optimize that? But if you're constantly getting told, 3,000 steps a day, 3,000 steps a day, but I don't want to do any activity, it's a bit of a pointless exercise. So the question is always mapping on your desire and your goal, and are you getting actionable information? So it's not that technology is neither good nor bad, it's whether it's useful.
Yes. So when people want to be proactive, okay, so I'm just coming back to anybody listening to this podcast who decides I'm going to go and pay attention to my heart health now. What do you advise them to do? Is it go to have bloods immediately, go to the GP? Where are we starting?
So the 4 pillars: exercise, nutrition, sleep, stress. From an exercise point of view, am I active enough for what my goals are? Now, if you're somebody who just wants to get out and do a bit of movement and you're not a professional athlete, step count is a fantastic way to give you a very good approximation. There's nothing magical about 10,000 steps a day, but are you getting roughly close to that? Secondly, from an exercise point of view, are you doing resistance training to actually maintain and build muscle mass so you can do the things that you want to do later in life? Are you simply hitting those targets? From a weight point of view, a simple calculation of your BMI will work, for the absolute majority of people. Okay. People complain about BMI, but it's right about 90+% of the time.
Okay, so just to stay in the normal range.
Stay in the normal range. If you want to get really precise about it, you can do DEXA scans and you can measure visceral adipose tissue. But for the majority of people, measure your BMI.
Okay.
Sleep. Are you getting between 7 and 9 hours of sleep a night? Don't get too worried about whether it's deep sleep or light sleep. And then stress in terms of a self-reflection exercise, in terms of, do I have a lot of things going on in my life that are impacting my quality of life or my ability to do those other three things? They're all things that you can do yourself at home without ever speaking to a clinician. Then your blood pressure. Again, I think people should be doing this themselves, not relying on their doctor. When you go to your doctor, you should be arriving with that 10-day average and handing it to them, rather than have them do the theatrics of, I'm going to check your blood pressure now, and not even pay attention to the result. So there are core metrics that you can do. In terms of the blood tests, everyone should get a cholesterol panel. Everyone should understand what their glucose levels are like. Acutely fasting in the morning, and there's an average called your HbA1c. Your primary care doctor will know about all of these. What are your liver enzymes like in terms of an assessment of any degree of fatty liver disease because of excess fat in the liver? Understanding what kidney function is like. Is your thyroid function normal? Often we will do the high sensitivity CRP as a marker of inflammation in that context. And then as you go down to more advanced testing, do you have an abnormal genetic cholesterol disorder, Lp(a)? And now you're moving on to other things like then cardiac CT, identifying whether you've got plaque in your coronary arteries.
So in that blood panel, so when you go in, when you're paying attention to the lifestyle metrics that you can look after yourself, you're going in requesting your bloods. Is there a set of numbers? And I know you prefer not to just look at the numbers in isolation, but will there be ideal numbers for most people?
There will be. So, I think you're doing pretty good if most of them fall within the normal range.
Okay.
But if you want to be much more kind of aggressive about it, you can look at, there's a difference between normal and optimal. And so a good physician will be able to make the distinction between normal and optimal. And
it's optimal for you, the individual, or there's an optimal range, which is pretty much for all women?
There's generally an optimal range for everyone. And it does make it a distinction between the two. So it depends. So it depends on how aggressive you want to be about pulling the lever of risk reduction.
Yeah.
For someone who just want to do the basics and get them right, getting into the normal range will be just fine for most people. Some people want to take a far more aggressive approach to it, and now you're driving down to optimal. But it depends on what your attitude or approach to it is. There's nothing right or wrong. There's just your approach to managing risk.
There's a lot to be said for understanding this and knowing about the goal is optimal, because when you go and get a blood test, I had one recently, and you get a text from the GP saying everything is normal, and you go, right, that's fine, I'll go off about my business. Don't know the numbers, don't know where it's at compared to anything else. We need to know this.
Yeah, this requires an awful lot of information and communication, and this mostly requires time. Primary care doctors are dealing with the tsunami of chronic diseases.
True.
And the thing that they have the least of is time. Most consultations will be between 6 and 10 minutes, and they're dealing often with multiple medical complaints at the same time. So it's an impossible task. So the idea of being able to sit down and go through those technical details becomes incredibly hard. I do try and spend more time with my own patients. For all of my patients that come and see me, they actually have to do a course prior in terms of giving kind of the basics and fundamentals of a lot of the things that we've talked about. What are the principles that we look at across those 4 pillars of exercise, nutrition, sleep and stress, and thinking about kind of the distinction between risk factor, disease, event, and some of the steps that we take to actually reduce risk. So this is my way of trying to amplify my knowledge and give it to my patients, so they get like over 2 hours of content prior to ever actually seeing me, and that exists after that they have as a reference as well.
So they understand the formula.
Correct.
That makes sense. Paddy, before we end, I want to talk about Soulspan just a little bit. I love this concept. You reference Jungian ideas about life's purpose being becoming who we are supposed to be or meant to be. Just tell me a little bit more about that.
So, as I said at the start, there's lifespan, healthspan, and soulspan. Lifespan is how long you live. Healthspan is the quality of how you think and move. But they are in service of giving you the opportunity to live the life that is most meaningful to you. That is not defined in years, or it's not defined in how many, meters you can run in a particular second. It is fundamentally down to your own appreciation of what it means to live a meaningful life. Carl Jung talks about this idea that the privilege of a lifetime is to become who you are. And so it is the process of becoming. There's not a destination. It is the continuous process of updating your idea of who you are. And are your actions in the world most aligned with those values and ideals? It is aligned with the ideals that we hold as intrinsic values. So intrinsic values are the things that you would do if no one were looking and no one were paying you to do them. Extrinsic values are the things that you do to trade for something else, money, power, prestige, but they only have currency to buy you something else. So are you living your life in such a way that you feel is the most kind of meaningful for you? Are they a reflection, your actions a reflection of your deepest intrinsic values? And everybody knows when they spend some time in silence and reflect on that, they will know what those actions are and what those values are. They're different for everybody, but everybody knows deep in their soul what those are. And so health is really about giving you the opportunity to pursue a meaningful life. Our time is short, and this is our one time to actually to do it and not look back with regrets.
I love that. I think that's so powerful. It's the point of it all, isn't it? The point of being healthy. Before we go, Paddy, what gives you hope in terms of health?
My kids, the fact that we can look at the night sky, that there's all these amazing things in the world. I think we see lots of polarization, but there's so many things that we can be grateful for. And I just think it takes time to actually really look at the things that are really important to us. And it is the idea of having hope for those things that gives us the motivation to live in the way that we want to do. As Friedrich Nietzsche says, he who has a why can bear almost any how. And so if you do not have a why, you will never figure out the how. So the goal of your life is to become who you are and to understand why you should do it. The how will figure itself out.
I love it. Thank you very much, Dr. Paddy Barrett. Thank you for checking in with us today. We hope this episode gave you clarity and insight. If you enjoyed this conversation, please make sure to like, subscribe, and share it with a woman you feel would enjoy this too. Image the Check-In is empowered by Boots, sponsored by Samsung, Waterstone Health, It's for Women, and Irish Life Health, and we are very grateful to them for helping us bring these conversations to you.